So we have quite a number of people who are just joining our webinar at the moment. We'll begin sharp at 11 o'clock, and I'll introduce everybody at that stage. But a very warm welcome to those of you who are joining us from all around the country. It's just that beauty of the webinar where we can connect people so easily these days. So just give us another minute or so and let people get joined up, and then we'll start properly. I see plenty more people still joining, still coming in, and we'll begin our event in about a minute's time. Okay, so we're just up at 11 o'clock, so we'll get going with our webinar proper this morning. So my name is Sheila Gilheany. I'm CEO of Alcohol Action Ireland, and you're very welcome to our event this morning on access to alcohol treatment, removing barriers to healthcare. Now, many of you would know that a significant proportion of the population, 15% in fact of our people in Ireland, would have an alcohol use disorder. However, according to the Health Research Board's data on alcohol treatment back in 2020, there were only just about 3,319 new presentations who gained access to alcohol treatment services. So there certainly seems to be a bit of a disconnect between the numbers of people who potentially might look to use a service and the numbers who are actually gaining access to that. And in fact, if we were even just to look at a report out from the HRB this morning, they would indicate there that a third of young drinkers actually would have an alcohol use disorder. So I'd say we have large numbers. Now, there are many different types of us who might actually potentially seek to use a service. There's divisions, I suppose, between whether people are living in rural areas or in urban, whether they're young, or, as I've just mentioned, or older, male or female, and people who, of course, are in different stages of recovery. And on top of all of that, everybody is an individual. We would all be bringing our own personal circumstances and preferences, and all of these things, I suppose, adds to a big mix and of reasons why people maybe do access treatment, or more importantly, why they don't, or why there is a barrier, or why there are difficulties. So this morning, what we're actually going to look to do is to explore some of those aspects. And we have contributions from a number of people here who are both have lived experience, and also from people who are service providers. Our speakers this morning include Professor Jo-Hanna Ivers from Trinity College, Dublin, Anita Harris, and who is the residential service manager at Coolmine Therapeutic community, and Emma, who has used services at Coolmine. We also have two speakers from the Finglas addiction support team. That's Amy Roche and Andy Robertson. And after all of them have spoken, we're going to have a panel discussion, and that will be chaired by Paddy Creedon. And Paddy is actually a board member of Alcohol Action Ireland. Just to let people know, the event will be recorded and will be made available afterwards, to anyone who's registered, and we'll probably make it available even more widely than that. And throughout the discussion this morning, there will be a chance for you to put questions to the panel. So I'd ask and invite you to do that in the chat box. We'll try and get to as many questions as we can in our discussion in the last 20 minutes, and some of them we might be able to answer actually in the chat box itself if we're not able to specifically get back to you. So with all of that, I think we're very close to just having most people who have registered coming into us. So I'm going to start here now and ask Professor Jo-Hanna Ivers to join us. Jo-Hanna is an assistant professor in addiction at Trinity College, Dublin. She holds the only addiction-specific academic post in Ireland. And she has a heap of great qualifications. I could go through them all here. She's the first Associate Dean of Civic Engagement and Social Innovation at TCD. She leads the Neurobehavioral Addiction Research Group. And she is also the Director of the MSc in Addiction Recovery. And she has brought her expertise to a number of different ministers and government representatives and various task forces and expert review groups. Now, last year, Jo-Hanna and a team that she was working with at Ballyfermot Star CLG and supported by the Tala and Ballyfermot task forces produced what I would really term a key report. It looked at supporting women to access appropriate treatment. And a lot of what Jo-Hanna is just going to talk about this morning is to look at some of the key aspects of the findings from that particular report. So if I'd ask Jo-Hanna if you wanted just to take over at this point and share your screen. Thanks very much. I'll let you kick off there.
Can everybody hear me clearly?
Yes, I can. Thank you.
Okay, so I'm Jo-Hanna Ivers. I'm based at the Institute of Population Health in Trinity College, Dublin. And as Sheila said, today I'm going to be sharing the findings of the Supporting Women to Access Appropriate Treatment, or the SWOT study. So the SWOT study also included the experiences of service providers, but for the interest of time and the focus of today, we're just going to present the findings on the women who took part and their kind of experience. So just to give you a very brief overview, I'm going to go through the who, the how, the when, the why, and the what, because ultimately that's kind of what we want to know about studies, isn't it? So as I go through, as I said, we accessed women who were receiving treatment either in the Ballyfermot or Tala community, and women who were also seeking recovery in both Ballyfermot and Tala. As I say, we also included a number of key stakeholders who were directly working with women and those indirectly, so policymakers, advocates, and community representatives. But as I say, I'm going to present the voice of the women today. So in terms of the how, we had a bit of a mixed methodology. So we had obviously a comprehensive review of the literature in order to frame the problem and to know what the research had said before us, where were the key barriers that we needed to kind of plug. We then entered into a community consultation. So it was a workshop style consultation where we engaged, as I said, women who were accessing treatment and women who were also attempting or had made a previous attempt to access treatment in the community. We also opened up an open submission where women who didn't feel comfortable or were not able to access or attend the consultation, we opened up this online anonymous submission, and we gave access to across social media for, again, trying to target those women who were in treatment and equally trying to reach those who weren't, asking them to, focus on the 3 key questions, which were, I suppose, the theme of the research. So what worked or what works when trying to engage women in treatment, what simply doesn't work, and what we need to do differently. The consultation was really important because it fed into, again, how we were going to access particular groups and the questions that we were going to ask them. So it was very much informed by the women in the community themselves. So the when was between November 2020 and April 21. So we were in the middle of a global pandemic. So for a lot of the interviews, they took place online. But again, when it came to the women, we really tried to access them within the guidance of public health, within the local community. So the majority of the women's interviews actually happened, or we tried to arrange that they happened in person in the community, but also some of them happened online for convenience to the women. So why did we kind of, or what was the so what of it all? Why do we want to undertake research specifically looking at targeting women or trying to understand why women show up or don't show up to treatment? So women make up approximately 1/3 of all people with a severe drug and alcohol problem. Yet approximately 1 in 5 presentations to treatment are a woman with a drug or alcohol use disorder. So again, you can see that the level of need and the level of presentation is disproportionate. So again, I suppose in terms of women and the barriers that women face when seeking treatment, just to give a very global overview. So women are more likely to experience stigma and social and economic disadvantage, more likely to have experienced sexual abuse, domestic violence. They're more likely to have less social support when it comes to their male peers, more likely to be a single parent. Where they are in a partnership, it's more likely to be with another drug user, which causes another level of dimension and another dimension rather, and level of dependence. And they're more likely to have experienced a parental substance abuse in their childhood. But to put it in concrete terms, I'm going to play Paula's kind of version.
It's really, really hard for women with kids, especially when they're left on their own with them. Like, how do you manage, running a home and doing dinners and rearing kids, and all the while, you've to make time for meetings and meeting up with a sponsor, doing the work, it takes a lot of work. And, I know a lot of these women that are still out there, and I see it in them. Like, I see the potential in them, and I see that, if they had the right things at their disposal, they would take off.
And I suppose for me, that's the real why, that there are many women in the community with massive potential to get recovery and to stay in recovery, to build a recovery capital, but they just don't get the opportunity. There are layers and layers of need in a woman's way before she actually gets to access treatment. So that's the real, I suppose, human impact of it. So again, just to give you a brief overview, because the women were included in the workshop consultation, as I say, we focus on 3 questions: what helped, what hindered, and what would they like to see done differently? So what helped was where there was an access or an increase to residential treatment. This was key for women. Community creche and funded childcare was something that was a starting point. Women with children, of which the majority of our participants had children, couldn't access treatment without that level of support, because remember, they're coming with very little community support anyway, in way of kind of family and friends that will be able to give them a dig out. And any increased access to mother and child residential treatment, which again we know is it's limited but growing, thankfully. Increased in awareness around available services. What didn't work then, not surprisingly, was lack of childcare, waiting lists, stigma, mental health issues. This was a theme that ran throughout, the usual. If you had a mental health issue, you needed to get that under control before you accessed addiction services. Lack of support from health professionals. Again, there was a lot of, I suppose, presentations in mainstream primary care and equally in hospital services where women felt stigmatized or judged, and as a consequence, didn't go to access those treatment services. Domestic violence and control from partners. What would they like to see done differently? Early intervention, drug education for adolescents, respite for mother and child. Again, I'll come back to this, but of the women that were parents, which were the majority of our participants, a high proportion of them were also the mother of a child with a special need or children with special needs. Again, they were calling for a lower threshold for domestic violence services. So again, women presenting with a history of drug or alcohol use or a drug and alcohol use disorder are prohibited from accessing these services. So again, a woman who was most in need of a service was not getting that. Gender specific supports and particularly peer-led groups. Again, in terms of the written submissions, we had 25 of those. So again, what helped prioritizing women's complex needs, keeping women's needs on the political agenda, interagency work, gender sensitive services. Interestingly, what women talked about was that initiation into treatment when they first connected with service, that they would like to see a service that was just women, because there was a lot of vulnerability, a history of, coercion and domestic violence. So in order to make that safe and accessible, women felt that at least the initial stages of treatment would be very important to have women-only services where a woman opted for that. And then as we go on to aftercare and building that capital to reintegrate services then so that, you know, they became more mainstream and they did have an opportunity to, I suppose, grow and develop their recovery capital alongside their male peers. What hindered, again, a very steady, consistent theme that ran out through this report was stigma and shame. Again, for younger women, opiate-centric services, so seeing community services as very much older clinics for people who use opiates, who are on methadone, so there was no place for me there, or my parents went there, or my aunt or uncle went there, and I don't want to go there. So again, that need to kind of, you know, make services, I suppose, less centric around a particular drug, and equally, you know, invite many or shake up the perception around what services do, who they're responding to, and whose needs will be met. Again, case management was seen as a positive that came from the submissions from the key stakeholders. So what would you like to see done differently? Again, gender sensitive services, long-term political and financial commitment, childcare, continuum of care, increased recovery supports, and adequate access to domestic violence and mother and child services. So in terms of, and this is, I suppose, the meat of what we're going to present today, which was the voices of the women. So getting behind the story of what worked for women when they got treatment, or equally what kind of kept them outside of treatment. So the what of this part of the study, I apologize, I'm quite croaky today. 6 major themes emerged from the interviews with women. So they focused on women's needs, barriers to accessing treatment, barriers experienced by mothers who use drugs or alcohol or have a drug and alcohol use disorder, women seeking recovery, health service engagement, and the necessary changes that we need to make in order to make treatment more accessible for this group. So again, just looking at the women's needs, trauma was a dominant factor in the women's narrative. So the vast majority of women, so 20 of the 22, had experienced trauma at some stage in their life. The women in the study, you know, typically described a childhood marked by poverty, bereavement, and family adversity. More than half shared an experience of abuse, parental drug use, domestic violence, and these were all central to both the beginning or the initiation of a drug use and therefore the escalation to a dependence. More than half of the women experienced multiple episodes of bereavement, including the loss of children, parents, and partners, and most of the deaths were traumatic and premature. So just to...
My mother and father, there was a lot of violence there because my father would have, like that, I would have said now looking back, alcohol didn't agree with it. And my mother would have had a dependency on drugs like sleeping tablets, relaxing tablets and stuff like that. And it was dysfunctional because of all of that, you know. So yeah, there would have been a lot of violence growing up.
I'm 45, I'm a mother of 4. I buried 2 partners through suicide, and I've been on drugs 30 odd years.
So, you know, the level of trauma was...
My mother and father.
Sorry. I suppose in terms of then theme 2, looking at barriers to accessing treatment, 2/3 of the women spoke about stigma. But again, stigma and shame were a theme that ran through all of the interviews. As I mentioned earlier, age was a consideration for a number of the women. So again, coming to accessing services and discounting themselves from a service because of a particular profile that they'd attached to a service. Again, the feeling of perceived judgment and ultimately the threat to their children overshadowed the thoughts of sharing their stories or accessing a treatment. And you know, I can't emphasize how much or how significant this theme was in terms of women not wanting to access treatment in order to keep their family safe. And we did talk about it in terms of a perceived feeling because it did keep them from accessing treatment. But just to give it validity, in one of the communities that we were researching, it had the highest rate of child removal from the family. So it was a real threat for women. Like, we talk about it as perceived threat here because, as I say, it's from their perspective. But actually, a lot of the women knew other families and indeed other women predominantly who had maybe lost a child due to addiction issues.
Yeah, it did affect my help seeking because, again, I was terrified to say that I was, you know, a mother that was struggling. For some reason, the perception I had was that you become a mother, then you do nothing wrong, and you just be a mother, and, you know, you don't put a foot wrong. And that's where it kind of all went wrong for me. It was this expectation of myself. So, yeah, it did stop me because I felt I had to be a certain way because I was a mother, you know, but still human at the end of the day, with or without kids. So that's the difference.
It really is. It's more anxious about where people think. Like, it isn't set up for us. And especially around here, it's like you're frowned upon. You're called, oh, she's dirty, you know, like she's a junkie, she's this, she's that. So I think it's, women kind of keep it private, whereas men are going around and they speak about where or what they want. Like, me personally, I wouldn't. My experience with my friends, I know they wouldn't.
Yeah, it did affect my
It really is.
thinking.
So in terms of then barriers experienced by mothers, so as I say, the majority of the women interviewed were parents, so 16 of the women were parents. The primary responsibility for the children often fell with the mother, didn't have a lot of access, as I say, to family help, and more often than not, the partner was not in the picture and therefore able to support. Almost a third of the women that were mothers that were interviewed were parenting a child or children with special needs. The lack of access to childcare services was cited as a significant barrier, and the majority of women feared sharing their story, as I say, and seeking help because they perceived the outcome as being punitive.
Like that with childcare, you can't, like, what stopped me going into treatment for a month or 2 months was my children. When it got then to the stage that my addiction got so bad, I lost my children anyway. If I had been able to link into the service and have childcare, I mightn't have lost them, and I could be like 8 years in recovery.
And again, an all too often story that we hear of women, you know, trying to protect and stay away from the service, but ultimately, you know, run into this difficulty in the end.
That would have been the biggest barrier, thinking that if I told somebody in a professional way that I would be punished, you know, having the perception that if you're a certain way, then you're going to be punished for that. So I would have had this perception that if I went in to go to somebody, they'd say, oh my God, you're a bad mother, you know. Actually, what you just done now and what you're doing, we're going to take your kids away. It's stuff like that that would have stopped me from reaching out and asking for help, definitely.
So in terms of seeking recovery, so what was the kind of story in terms of women when they did seek treatment? So the majority of women spoke about reaching out when they were at absolute rock bottom. So when there was nowhere else to go, or when they stayed away from treatment because the fear was that their child would be taken, like Sharon spoke about, but in the end that happened anyway. And what we see is a woman in need with a lot of complex needs, eventually showing up to treatment in dire need. And I think that that's, you know, the one thing we can improve is getting earlier access for women is really what we need to be focusing on. So friends were a key support of information, so telling people about local services, but ultimately role modeling that recovery was really important, and that point of relativity that women could see, like, oh, you know, I went to school with her and look at her now, or we used to use together, she was as bad as me and look, she's got recovery. That really inspired women to want to, I suppose, access treatment. But as I say, it offered that role model and that kind of visibility of recovery in the community and the possibility of recovery in the community. So peers were obviously a key motivator for change. And all of the women, just to say, really had an intrinsic motivation to want to seek recovery. And ironically, or maybe not ironically, but the things that keep women outside treatment, like fear of losing their children, or fear of being stigmatized or shamed, once a woman gets recovery, we know that they build capital quite quickly. So there is an onus on us to kind of improve that and give women an equal chance.
I lost pretty much everything over it. My child, my dignity sometimes, things I had to do to get the money for it, which I won't go into at the moment. The only thing I have left is my home, and I'm really holding on to it by a string.
Like, I wanted to get clean. It didn't work, but I did want to. Do you know, that was the start to something inside me saying, I want a better life. Do you know that way?
So in terms of their level of engagement with the health service, accessing adequate healthcare was not easy for women, again, because of the reasons I just mentioned. The women's engagement with services was marked by a lack of empowerment and autonomy. So again, when they showed up at treatment, there wasn't a sense of wanting them to kind of, you know, recover. Often women talked about the methadone maintenance program and the fact that accessing treatment or accessing a pathway away from a treatment that they had for many years was not made easy by healthcare professionals. So women shared their frustration around the cyclical loop that they found themselves in when seeking help for co-occurring mental health issues. And again, this is a theme that's not new to any of us. The notion that if you have a co-occurring mental health issue and an addiction issue, that you can't, one service is sending you back to seek the help of another, and all it does is send people around in circles.
Because like that, I was constantly up against a battle of, if I went in and I had a flu, my doctor wanted to put me back up on methadone. And, you know, it was like, you know, you can't do it. No, I will do it. No, I'm telling you, you'll be back to me. And this is giving me all these statistics of the amount of people that relapse. It was often, you know, at the time you don't have any self-esteem. No, and here's someone in a position of power telling you it's not going to happen.
Sorry, I seem to have lost my audio, but I'll just give you a second to read Elaine's quote just around her access to mental health. So again, just encompassing that notion that, you know, we need to do better in that space between, and that linkage between mental health and drug and alcohol disorder. So the final theme then was the necessary changes. So what women wanted to see done that would either help them sustain a recovery or initiate them into treatment to gain or access recovery services. So the development of a gender sensitive service, development of age and substance specific services. So again, going back to the need of the presentation as opposed to the historical you know, service that's provided in communities. increased visibility of recovery and recovery supports. And again, that was really driven by the peer-led stuff. Both communities had embarked on a small number of recovery coaches, and they were doing tremendous work just getting out into the community, as I say, role modeling, accessing, outreaching women, and drawing them into meetings and treatment services.
They don't know there's a way out because it's not shared enough. It's not given out. It's not spoken about, you know. So there needs to be more advertising, publicising. I don't know what you want to call it, but it needs to be put out there that, you know, this is an everyday ongoing thing. This happens all the time, a huge percentage, and if you're one of them, then there's help out there, you know.
Yeah, I feel that they should have women only, because when you're going through that, the last thing you want, especially with my experience, you don't want to be around men. You know what I mean? And like, I know, God, I'm not saying anything against them. I just, if there was women only areas, I think women would be more inclined, especially because I have a lot of friends that have bad histories with ex-partners. So you know what I mean. Even they got them in the door there first, and then they, you know, like myself, they built up the confidence and do that. They go outside, but I think, yeah, there should definitely be women only for it, you know, locally.
So in terms of key recommendations, and just to say the recommendations are based on predominantly the women's experience and voices, but also key stakeholders who work with women directly, like service providers, and equally indirectly advocates, community representatives, and policymakers. So there was, at all of those levels, there was a shared vision to develop an adequate trauma-informed response for women who use drugs, to establish gender transformative integrated treatment and support services for women who use drugs and alcohol, establish a working group between the Ballyfermot and Tala local drug and alcohol task forces and the Child and Family Agency. I believe that initial work has gone on there, and there is tremendous work gone on with the SWAT coordinator to try and implement some of these changes, develop pathways for women to sustain recovery, expand pathways to education and training for women, and support women to rebuild and sustain healthy family relationships. So thank you for your time, but I'd just like to give a small shout out, if I can, to my co-author, Professor Gillian Paul from DCU, Sunniva Finlay, Clara Guiney, Niamh McGuinness, and Denise Joy, who made up our research advisory group, and my research assistant at the time, Franca Gullini. So thank you for your time.
Thanks very much indeed for that, Jo-Hanna. I have to say, actually, I'm so glad you were able to incorporate the voices of the women who had participated in that. That's very powerful just to hear that, and really, I think, speaks volumes, even more so than, you know, the carefully crafted language of your excellent report. But I think just to hear those voices is very important. Very struck by the recommendations, and I know we're going to come back and talk a little bit more about that. But I think it is so clear, and you hear the voice of trauma that's from these women, of why we need a trauma-informed response, you know, in any services. So thank you very much indeed. We will come back to you, but at the moment what we want to do is to move on to our second set of speakers. And I'm joined now from colleagues from the Coolmine Therapeutic community, and in particular Anita Harris. Now Anita is Coolmine's residential service managers, and she's somebody, she would describe herself as a practitioner who strongly believes in the therapeutic community model as an effective drug and alcohol treatment approach. And I know you say that can work with all populations. I'm also very interested in actually just some of your own particular passions that around looking at the evidence, trying to reduce the barriers, the stigma and the challenges for men, women and families. And I note as well that Anita is also a parenting under pressure therapist, and you're actually supervising the first PUP training hub in Ireland. And Anita, I know you're going to be presenting along with a client with lived experience. So you're joined here as well by Emma Kinsella, and just going to talk a little bit more about, I suppose, the focus on pathways to treatment. You can look at some of the data around clients, and then what that experience is actually like. So I'm going to hand over to our Coolmine colleagues at this point. Thank you. And Anita, just ask you to unmute yourself there.
Can all hear me now?
We can indeed.
Thanks very much, Sheila, and thanks for the invite today to speak today. And as Sheila said, I am the Residential Services Manager in Coolmine, and the focus of my presentation today will be on that there is many different pathways and approaches to recovery. I will also try to share some examples of good practice in treating alcohol dependence within Coolmine services with a focus on dual diagnosis and the challenges. I do think it's important, prior to going into many different pathways and many different approaches, I suppose just to give a very brief overview, that traditionally Coolmine had that there was one pathway and that there was one approach, and that was the therapeutic community approach to addiction. And just to say, just because I think it is really important to say that, because it has evolved since then. It first opened in 1973 with a very, very strong focus on community as method and abstinence as the only way to achieve recovery from either drug or alcohol abuse. For many of you, just very briefly, that what a therapeutic community approach is. It's people coming to live together in a very highly structured environment, where the peer are the experts. There is no experts in terms of the professionals giving advice, that the peer are their own counsellors. It's a very highly structured environment where learning occurs through the identifying whether there's an active participation in the programme. It is, I suppose, it has evolved, and to date the TC approach to recovery remains in all the Coolmine abstinence-based programmes, but its vision of recovery has evolved over the years, and its recognition and commitment to programme development that recognises that quality of life rather than mere abstinence from drug and alcohol is critical. Quality of life, this includes enhanced family and interpersonal relationships, health, housing, education and training and employment. And as Jo-Hanna had spoke about earlier, helping the person to build up their recovery capital. Its vision that everyone should have the opportunity to overcome addiction has remained. That is our vision since 1973, and it remains the vision that everybody, and I think the key part of that is opportunity. And it's great today that the focus of this is removing barriers and challenges to people having the equal opportunity to access treatment. It has evolved, and we will go on to a whole range of continuum of care in recognition that there are many pathways, many approaches, and developing pathways and increasing opportunities for individuals to access, regardless of substance, gender, race, ethnicity, or circumstances, has become the priority of the last 3 to 4 strategic plans from Coolmine. As a result, Coolmine now provides a wide range of community and day services at all stages of the continuum of care. I think it's important to say all the services on this are not specific to alcohol only. They are for drug and alcohol dependence, apart from one service, which I will speak about shortly, which is the alcohol programme, which is located, it's a very specific programme located in the Dublin 15 area. But these continuum are not particularly linear. So where we have at start of contact and assessment, we have a number of stabilisation, reduced use and contingency management. There's a recognition that if this is somebody's recovery goal, they will be supported. We have got primary treatment, which includes 2 residentials, one for men and women. We do have, up until very recently, Ashleigh House being the only mother and child, we have just recently opened a second mother and child in the Midwest of the country based in Limerick, where women can access treatment accompanied by their children. So I think before, because it is, I suppose this presentation is on alcohol and I do want to keep it located to there. I think this is represents, as I say again, who's not involved here is the Dublin 15 alcohol programme, because that is very specific to alcohol. But from a range of services that you could see on the previous slide there, this is showing all admissions to each service in 2021. And it's a percentage of who was presenting as their primary issue as alcohol. Now, as we know, working in the services, there's much polydrug use, but these were specifically for people who presented that alcohol was the substance that they were seeking treatment. You look at this presentation here, Coolmine House, which is located in the city centre, 11.5% of all those presenting to Coolmine House was for alcohol as their primary. We see a significant difference here in the southwest of the country, which includes Cork and Kerry. 53% of all admissions and all presentations for treatment in the Cork and Kerry was alcohol as their primary issue. The Midwest of the country, which includes Limerick, Clare, 36% of all admissions to any of the services in Limerick were all for alcohol. Coolmine Lodge, 13%, so that's our men's residential, 13% of those presenting to residential treatment was for alcohol, and Ashleigh House, 25% of all admissions to Ashleigh House residential treatment centre was alcohol was cited as their primary issue for which they were seeking treatment. One service that I didn't place on that, as I said, and I spoke about earlier, was the Dublin 15 alcohol programme, which is located in the community addiction team. This is a very specific community alcohol programme, and one that I present in here of a model that fits. It is a good practice programme that is located in Dublin 15, and a really, really effective programme. This is specified to people living in the community, and we do think of this factor, that this is one of the factors that does make it quite effective, and situated within Tier 4 and underpinned by CBT and MI. The main referrers to this programme are self, family and probation. So I think it was really important to put, because it is, there was 92% retention. This is a 20-week alcohol programme. And there was 92% retention in this programme in 2021. And I think one of the more significant findings, this programme always has higher female attendance than men. So if we see there in 2021, there was 61% of all participants on the alcohol programme were female, with 39%. This is a very different trend to any other service provided, where usually there is a higher presentation of men to women. And it's a programme that has demonstrated that increased structure has produced better outcomes. There has been a lot of, we have tried to find out what's the factors that have contributed to the effectiveness of this programme. And what we have found is that the increase of structure from a 12-week to a 20-week period, which includes 2 groups a week plus 1 workshop, really is suiting the needs of the people that's attending this programme. The workshops are based on the needs of the existing group at the time and can include relapse prevention, mindfulness, social supports, and a number of other psychoeducational workshops. But one of the factors as to why this is really successful with women, and in particular mothers, is the mix of facilitators. So there's a male and female facilitator of the programme. Where it is located, so it is quite discreet. It's a quite discreet location of where the Dublin 15 programme, and probably one that is more effective. It's located, the times of the groups are set to inside the hours of the school runs to accommodate mothers. So what we were finding was a 9:30 and 9 o'clock programme starts. We're not working with women or mothers because there was school runs. Some afternoon groups that were set at 2 o'clock was also interfering with school runs for 2:30 and 3:30. So the whole programme is set with inside the hours of the school runs to accommodate mothers. Suppose just to give you a very brief pathway to that alcohol programme, where we have our referral, I've said earlier, a lot of it is self-referral, family referral, and probation are probably one of the biggest referrers to this programme, where anybody is assessed. They can either, where I put as pre-entry, this is used as a pre-entry to the alcohol program, which is alcohol free when they get to the main structured program. However, there is a reduced use group if that is the pathway and that is the recovery goal for those that wish to present. The treatment there is case management and one reduced use group. The 20-week alcohol-free program is 3 groups weekly for a period of 20 weeks plus 1 key working session per week. And then progression to aftercare, which is for 8 weeks. For some clients, a progression pathway to residential treatment may be considered for those finding it too difficult to remain sober in the community, which is one of the most challenges, where I will get to for people presenting at pre-entry stage for access to the alcohol program. In the event of relapse in the alcohol program, people are engaged back at the reduced use and case management is offered at that stage. For many women, and I think Emma will speak about this when she comes on herself, trying to stay sober or get sober in the community is a very, very difficult and challenging aspect. And for a lot of the women, they find it too difficult to engage with community services due to many, many reasons. A residential program may be considered. And I'll refer back to the chart where we put up the statistics earlier. Alcohol has always, for the past 20 years, been the second most prevalent issue for which women are seeking residential treatment in Ashleigh after opiates. And it's something that I always find really, really interesting. With the statistic for the men's programs and the female programs, opiates, alcohol, and benzodiazepine are the 3 most prevalent substances for which women are seeking treatment, whereas cocaine, we hear a lot about cocaine. We're seeing that and witnessing that in a lot of the men's services. So an example also of good practice in Ashleigh House, for those of you that are not aware of Ashleigh House, it is a gender-specific residential that includes a mother and child facility where mothers can access treatment accompanied by their children. There's on-site childcare on-site where the children have their own individual care plans, and we have a very dedicated childcare team there who work with the children while the mother receives her treatment on a daily basis. The main referrers to Ashleigh House include community addiction services. This is for people that find it difficult to engage or remain engaged with community services, psychiatric and acute hospitals, detox facilities, and probation. Just to give, most women, if not all, have attempted community programs prior to entry. As Jo-Hanna spoke about there, many presenting to Ashleigh House are presenting with very complex physical and mental health support needs. Addiction is just one factor. And the approach to treatment that we have in Ashleigh House is the TC approach, where there's a strong focus on community as method, behaviour modification, and emotional management. I'd like to note at this point, not all persons presenting with alcohol issues have complex needs, but in our experience, the clients presenting to all of the Coolmine services, this is the case. Similar to treating any substance misuse, treating individuals with alcohol dependence or addiction requires a holistic care plan that addresses all their support needs. Treating addiction in isolation seems to us fruitless at times, and there are many challenges and support needs that require an interagency response and very often a multidisciplinary support plan. What is the treatment at Ashleigh House? So it is a minimum of 5 months residential treatment followed by 2 months integration and 5 months aftercare. As I said, up until recently, we were the only mother and child facility in the country. On-site childcare. We do have an on-site nursing team that is there daily, 7 days a week, and probably one of our most effective proactive supports that we got in place in very recent years after many years of lobbying was a visiting psychiatrist that can help support the mental health needs. This includes medication assessments and mental health supports of many of the women presenting to Ashleigh House. We have a visiting GP also that helps support the physical health needs. And I suppose just the biggest challenge, to Ashleigh House remains is access to mental health supports if a person has not been linked with these supports prior to entry. Another example, I suppose, where I'm leading, the biggest challenge in Dublin is access to mental health supports. But where I'm going to give is it's quite geographical, because in our southwest of the country where we have, I'm going to give an example of very good and solid pathways between the mental health services and addiction services. So an example of this good practice, and I just put up a little map there because Cork is huge. It's absolute huge, and I just felt that I had to put up just to show the kind of wide geographical area just before we do get to the challenges and the barriers to access by getting, I suppose, a snapshot of the map. But an example of good practice where pathways and collaborations with mental health teams has been established is in the southwest of the country. Coolmine currently have 6 recovery hubs in our operation covering Cork City, north and south, in addition to a number of satellite clinics covering the wider geographical areas of East, West and North Cork and in Kerry, where it would not be possible to meet the needs of everyone on the catchment area of one location. These clinics take place in various community buildings such as family resource centres or community mental health buildings. Services provided in these satellite clinics include assessments, key work and case management, and more recently introduction of some group programmes to the satellite clinics. There are several pathways to the southwest for clients with alcohol as their primary issue, and if we refer back to the earlier slide, 53%, that was 100. There was 345 individuals that received support in the Cork services in the last 6 months of 2021. 53% of these were alcohol as their main issue. While most are self-referrals, there is a growing number of referrals from mental health services. The unique example of this, and I suppose an example of a really good collaboration, is a referral pathway established with the liaison psychiatric team in the 2 major hospitals in Cork City for alcohol-specific clients. In West Cork and City South Hub, Coolmine satellite clinics are based in the HSC's community mental health buildings, which has led to ease of access to Coolmine and addiction services for the mental health team and a number of very successful collaborative care plans. So if we see there again, when I say there's no real gender difference, it was slightly higher females as presentations, but nothing significant. The main treatment supports provided in the Cork Kerry area are case management and key work, and CRA is the primary model. And we are beginning to see groups emerging, which I suppose is Coolmine's dominant treatment therapy is group therapy. So we are starting to see that now emerge in the Cork hubs as another program. So this is, I suppose, just to give a very snapshot of that referral pathway and how that is working at the moment. So referral from acute hospitals, this is prior to discharge from hospital, because this was a huge challenge and obstacle that was noted in the addiction services. Referrals were coming following discharges from hospitals. So there's been a lot of work now that a referral from the acute hospitals comes at least minimum 1 week before somebody is discharged from a hospital. Case conference if appropriate, and a strong emphasis on GP liaison if there's high support needs. The refer to the nearest community hub or satellite clinic. This can include collaborative care planning with the referrer, and the supports include case management, group and key working. Onward referral is a direct pathway to Coolmine residentials for long treatment if required, and there's a very established shared 2-way pathway with Tabor Lodge for shorter residential if this is the recovery goal. Whilst there has been a lot of positive progress made in the addiction sector in recognising that there are many pathways for persons accessing treatment for alcohol use and different approaches as not one size fits all, there remains many barriers for persons with either problematic alcohol use or dependence that requires a national strategic response. Some of the barriers and challenges noted include, so I have broken these up to challenges for the person accessing and then challenges for people once accessed. So similar to Joanne, you know, what Jo-Hanna was speaking about earlier, the biggest dominant challenge for a person, and particularly a mother and a woman, is fear of social services. So it is great to see in the recommendations of Jo-Hanna's report there about the need for a strategic collaboration between social services and addiction services. There needs to be some kind of consultation there, because this dominates every woman's experience of access and treatment, fear of children being removed. Childcare, practical challenges in access and stigma, again, like Jo-Hanna talked about, huge, either perceived stigma or very real stigma. Lack of information on range of services and how to access services. I found that really, really interesting. Most people, when we asked, they said they had to Google where you get alcohol treatment. So it's not readily available information. And for many people who found the alcohol program in Dublin 15 or many of the alcohol, unless that they were at crisis point, like Jo-Hanna was speaking about, where a professional had to do a direct referral pathway, many of them had to go searching for information on how they would access alcohol treatment or services. Complex physical health needs makes it very difficult for many to access community-based services, and complex mental and intellectual health issues with limited capacity to engage. These were noted as many challenges for a person to access and treatment. A big one, I suppose, that came from both the Southwest, the Midwest and Dublin was lack of residential detox facilities. Many challenges for person access and treatment is finding community detox with the help of their GP very, very difficult to remain to achieve their goals in the community. And whilst Cork have done, while I suppose the Southwest have done particularly great work in trying to eliminate many of the barriers in access, it is still a wide geographical area. Which does make it very, very difficult, particularly older clients who are quite isolated, to engage with any services. And this is compounded by lack of transport to help them access a service. For many reasons, clients unable to drive. So this was many factors. Either some clients banned from driving for drink driving, or unable to drive due to complex physical health, or just do not have possession of a car. Many clients are dependent on others to drive them to services and engagement. Again, we're talking about a lot of this is in the rural areas where there wouldn't be direct bus pathways. Challenges for services working with clients. So I suppose a lot of my focus here has gone on, working with people with mental health needs and trying to support them in collaboration with each other instead of in isolation from each other. Pathways with referrals from mental health services got a lot better. However, there still remains a lot of issues with pathways from addiction services to mental health services. So while there's been a lot of work done on one section of it, addiction services are starting, and there's been a lot of work taking referrals from. Services are still to this day finding it very, very difficult to refer to mental health services. More focus required in sober spaces and pro-social activity when sober. So this was an interesting one when we speak to and when we talk about recovery pathways. So many people whose sobriety actually is their treatment and their recovery goal. Many challenges has been pro-social activity for people that are sober. So when we talk about there's been a lot of progress in terms of recovery cafes and sober spaces, but I suppose feedback from many people that are sober is there is no distinction between who is sober and who is not sober, and that it's a free for all and open for all. So this has been, I suppose, noted as a challenge for people that have selected sobriety as their treatment goal. I will conclude my presentation by handing you over to Emma, who will give you an overview on her pathway to, through and out of services, and I suppose really provide an insight to the complexities of living with alcohol issues, getting treatment, and that there's not a linear pathway to recovery. She demonstrates that recovery pathway taken by many, and that recovery from alcohol dependence is both possible and achievable. So thank you from me, and I will hand you to Emma now.
Good morning. My name is Emma, and I graduated from Ashleigh House, which is Coolmine's female residential treatment centre, in 2018. I'm going to share my experience of access and treatment for my alcohol addiction, but to give some context, I think it's relevant to share a little bit about my background. I come from a large family where there was no significant history of alcoholism or mental health issues. I had a stable home growing up and a relatively normal family life. I had a good education, and after college, I started training as an accountant. My life looked pretty good from the outside, but there were some issues beneath the surface. Unknown to my parents, a male relative had been acting inappropriately towards me from a young age, and I was severely traumatized by this. I felt I couldn't tell anyone, as I blamed myself for it all, and I felt so ashamed of what had happened. To try to control my feelings around all of this, I had been self-harming regularly from a young age. But when I discovered alcohol in my teens, it seemed the perfect substitute for self-harm as a coping mechanism. It numbed all the negative feelings, but I guess in a socially acceptable way. I couldn't tell you exactly when I crossed the line from social drinking to harmful drinking, or later from harmful drinking to full-blown addiction. Alcohol is just so insidious. It makes you feel like you're in control when you absolutely are not. It's safe to say that by my mid-20s, I was certainly drinking alcoholically, but at the time, I was a very functional alcoholic. Yes, I drank myself to sleep every night, but from my point of view, so long as I fulfilled my responsibilities and working at home, who could fault me for that? It's clear to me now that my mental health had always been fragile, despite the fact that I would have probably seemed calm and in control to those around me. But everything changed when I became a mum in 2014. For several months after my baby, William, was born, I suffered extreme panic and anxiety, and at many times I felt that I was losing touch with reality. I was so paranoid. I felt like my baby and myself were constantly in danger. It wasn't long before I started drinking again, and alcohol did what it had always done for me. It numbed me, it switched off all the feelings. It gave me a break from the dark thoughts that I was having, from the overwhelming fear and anxiety. My son was 18 months old when I was first admitted for treatment in 2015 to St. Patrick's Psychiatric Hospital. At this time, I was still in a relationship with my son's dad, and we had home together, the three of us, and I had a good job to return to after treatment, all going well. At that time, I thought that being admitted to a psychiatric hospital was to be my rock bottom in life, but I was wrong. As it turns out, this was to be only the first of countless medical detoxes for me. At the time, knowing absolutely nothing about alcoholism, I wasn't even aware of the need to be medically detoxed from alcohol. Detox to me meant detoxing from hard drugs. Many people don't realize that an unsupervised detox from alcohol can be extremely dangerous. This is a huge barrier to recovery in itself. Inpatient alcohol detox facilities are so difficult to access, and in my experience anyways, it's pretty much impossible to detox safely as an outpatient, even if you are lucky enough to have medical support. Anyways, once detoxed, I began an addiction recovery program in St. Pat's. I wasn't one of the people who were lucky enough to get recovery first time around. I relapsed on completion of that first inpatient program, and that's when my partner moved out of our home, taking our son with him. He then requested custody of our son through the family courts, and he got it. I didn't have a leg to stand on at the time. From that point on, I only had very limited access with my son, and any access we did have had to be supervised. I couldn't afford to keep our home on my own, so that was the next thing to go. At some stage, my employer couldn't keep holding my job open for me, so that was gone too. I was waking up every morning faced with the disastrous consequences of my addiction, and the only thing that helped me cope, alcohol, was the very thing that had gotten me here. Over the next couple of years, I was admitted to several different treatment centres, but I always relapsed very soon after discharge. A big factor in this was that I never had a home to go to after completion of a programme. Following discharge, I usually just ended up bouncing around between friends' houses, almost all of whom were in active addiction. I often ended up in homeless hostels or occasionally on the streets. It just all seemed completely hopeless. I also had several admissions to St. Patrick's Hospital in this time. They did their absolute best for me, but it was clear that a longer-term residential programme was needed. They suggested Coolmine, so I started doing pre-entry groups while still an inpatient in St. Pat's. I think it's important to mention that doing the pre-entries for Coolmine and staying clean and sober for them is a massive achievement for any addict or alcoholic, especially if you don't have a stable home environment at the time. I was incredibly lucky to have St. Pat's, a safe place to return to between the pre-entry sessions, as I don't know how I'd ever managed to stay alcohol-free long enough to get on the programme otherwise. I finally started the residential programme in Coolmine in November 2017. I was relieved to be there, but I was also mentally in a very dark place. I had lost everything that mattered in my life, And while I was willing to give this new program a go, what would actually be any different? I tried and failed so many times, and my little boy, now 3 years old, was growing up so quickly without me. And most of the time anyways, I believed that he was better off without me in his life at all. I felt like such a toxic, weak, worthless person. How could I possibly be a positive force in anyone's life? But I decided to put my head down and give Ashleigh House my best shot. I was about 2 months into the program when my mental health took a sudden turn for the worse. So many feelings that had been suppressed by the alcohol for many years were coming to the surface and completely overwhelming me. I went from being sad and anxious, but managing, to feeling the unstoppable need to self-harm or worse pretty much overnight. I could feel myself losing control again, and it was terrifying. This is where in the past I would have either self-discharged or more likely just absconded from the treatment centre. However, this time I made myself talk to the staff in Ashleigh House, and it was decided I needed to go back to St. Pat's Hospital immediately to restabilise my mental health. I was not being discharged from the Coolmine programme. My bed there was being kept for me, and I would rejoin the programme exactly where I left off. This meant the world to me. So many times in the past, addiction treatment centres would discharge me or turn me away in the first place because my mental health issues were too complicated or too unstable or just too much. So Coolmine arranged for me to be transferred to St. Pat's immediately. I was now in a safe and familiar place under the guidance of a team of medical professionals who already knew me and my history very well. My medication was reviewed straight away by the psychiatrist who'd known me for years, and a few changes were made. I stayed in the hospital for around a month to make sure I was well settled on a new medication. During this time, it was arranged that I could actually leave the hospital every day, get the bus to Ashleigh House, attend my groups there, and then return to the hospital in the evenings. This was incredibly accommodating of both the hospital and Coolmine. And for me, it meant that I wasn't putting my recovery on hold while I addressed my mental health issues. I learned that it's certainly not easy to prioritise addiction recovery and mental illness treatment at the same time, but that it can be done. And in my case, it needed to be done that way. I was never going to get well by trying to treat separate aspects of my dual diagnosis in isolation of each other. Once I was stabilised on the new medication, I was discharged to St. Pat's and returned full-time to Ashleigh House. I had plenty of ups and downs throughout the remainder of my residential programme, which lasted 7 months in total, but I needed no further hospitalisations during this time. Almost all of the women in Ashleigh House during my time there were mums, around half of whom had their children with them, but the remainder, like me, did not. However, I didn't miss any scheduled access visits during my time in Ashleigh House. Once a week, I was allowed to pick William up from his creche and spend the afternoon with him. As I progressed in the programme, he was able to visit me in Ashleigh House for overnights and weekends. He absolutely loved the house, and he made some great friends among the other children there. Only recently, he said to me, "Do you remember when you used to live in that big house with the Rainbow Bridge with all your friends there?" And I think that's just such a lovely childhood memory for him to have, that he's only positive associations with the time I spent in treatment. I left Ashleigh House in the summer of 2018. For the first time, I wasn't leaving a treatment centre to homelessness. They helped arrange a place for me in a transition house, where I stayed until I found an apartment to rent on my own. I attended a daily step-down programme at first, and from there started on a C scheme, working with Coolmine for a few months. In recovery, I didn't get my old pre-addiction life back. Instead, I built up a new and better life for myself. Nothing happened overnight. It was a very gradual process, one decision at a time, one day at a time. I'm really pleased and grateful to be able to say that these days I have a stable, productive, healthy life. I have a safe place to live. My son's father and I have a really great co-parenting relationship with open and honest communication, and with my son having plenty of time with each of us. William is a happy, healthy 8-year-old now. I'm back working in finance the last couple of years. I have a job that I love in a really great company. I have rebuilt many damaged relationships with family members and friends. I am still closely linked in with both St. Pat's and Coolmine, and I probably always will be. While I live a very independent life these days, it's great to have strong supports that I can rely on when I need them. I would like to think that my story hopefully illustrates that recovery is possible for anyone, no matter how chronic their addiction is, no matter how many complicating factors are thrown in the mix. There is, in my opinion, no such thing as a straightforward case of addiction or alcoholism. A person that presents for addiction treatment, and there will almost always be mental health issues, whether diagnosed or not, to consider. There will usually be trauma in the person's past, whether it preceded the addiction or came about as a result of the addiction. There are, of course, very often medical issues that need to be monitored too, and various family and social issues. There are just so many moving parts, so many complex needs that all need to be met in order for a person to embark on the journey of recovery. If a holistic approach is taken, if these issues are faced head on and addressed as an integral part of the person's care plan, in my opinion, it will much improve the chances of successful recovery. And with that, I'll hand you back to Anita. Thank you.
Thanks very much, Emma. And I suppose for my whole presentation, Emma has just went through, I suppose, a referral pathway in, out, and I suppose progress and truth. Thanks very, very much, Emma. I'll hand you back over to Sheila.
Oh, thank you very much, Anita and Emma. Honestly, I'm blown away. I'm actually texting our colleagues here as we speak, and we're just thank you very, very much for what you've just shared there. It does give hope, and it does, I think, illustrate very well, Anita, what you were saying about different pathways and I suppose very much just that individual need to have a pathway that works for the individual. I think is something that I think is critically important. I'm aware that we are going over a little bit in our time, but I wouldn't have missed literally a second of that. So maybe just say to our to people who are listening that we'll probably extend this a little bit. So we might actually run over. I would say we'll probably go up to nearly 1 o'clock. So I hope that's okay. But I hope you'll also agree that we've been getting a lot out of what we've been discussing this morning. So moving on to our third set of speakers this morning, we're going to move over to Finglas, to the Finglas Addiction Support Team. And we are joined this morning by Amy Roche and Andy Robertson. So Amy is the CEO of FAST, and she's a lot of experience in working in the charity sector in many different ways. I think actually you'd also previously worked possibly at Coolmine as well, but now over with Finglas. And I know Amy's what you're aiming to do this morning is to present a kind of a snapshot of the individuals who would be seeking services in Dublin Northwest, and kind of looking at some of the gaps and the blocks to maybe getting to those services. And Andy is a psychotherapist working with FAST, and I know you have many decades, actually at least three decades of experience in this area. You're going to be looking at the sort of the continuum of care that is offered and the needs of those presenting to FAST for alcohol treatment services. So I'll hand over firstly to Amy, and we'll get going from there. Thank you.
Thank you very much, Sheila. And I am very conscious of time, so I have a timer beside me, but I'm happy to get a prompt from anybody here to say, time's up. So I don't want to keep people too long, and I appreciate you taking the time to go over to get our presentation in. Massive thank you to everyone beforehand to lead to this point. I feel like I've little to say, but I have some points to cover because it's all very consistent, and the messages from Jo-Hanna, from that research from Coolmine, and really importantly from Emma, echo that there is such complexity for people, and access to treatment has to be flexible and has to be in keeping with the needs presenting, not this, as Anita already said, this linear pathway. So part of our presentation will cover that, and thank you, Sheila, and to Alcohol Action Ireland for having this webinar as well. So I have a presentation because I felt like I needed to have one because everyone had one. So I have to keep me on track anyway. And I'm going to attempt to share it. If it doesn't work, I'm going to give up very quickly. Has that worked?
That's lovely. I can see it there. Thank you.
There we go. So I work for Finglas Addiction Support Team. I'm there since 2019, and just briefly, I won't go into too much just because of time. Finglas Addiction Support Team, known as FAST, has been providing services in Cavan and Finglas for 18 years, and it goes outside there to other parts of Dublin Northwest. The service is a community addiction team, and it provides services on a continuum to people with drug and alcohol, problematic drug and alcohol use, and family support as well, so supporting family members. We provide services across the continuum, from our outreach services which include assertive outreach, social inclusion work, soon to be launched a mobile health service to services in our facility. We have information assessment sessions. We have a 6-month day program, aftercare, family support services, and we have a cocaine and alcohol support group, which is a 10-week program using the resonance factor model. But that program is focused more on earlier intervention, and I'll explain a little bit about that in a minute. And just a snapshot of FAST. So, look, I could do this for the last 18 years, but like all services, our demand for service provision has grown year on year. And in the since 2018 to last year, we've had a 52% increase in our services provided. And I always say when I say that, that doesn't mean that there isn't more people. That's just our capacity. It doesn't represent a true reflection of the services that are needed. It's just what we can deliver. So a brief look at our main substances. So Anita talked about primary substance use there. So that's the substance that an individual will note when assessed initially. What are you presenting with? What is your primary issue? And consistently, and again, I'm only going back 3 years, alcohol is the second most noted main problem substance. And Anita said the same thing, particularly with women. And with women in FAST, actually, if you split it into gender figures, women are more likely to report alcohol as their main substance of choice than men. Men, it's cocaine in our communities, in our community services. So just to briefly mention, alcohol is also, as part of the national figures, and Anita talked there as well about polydrug use, is the most reported additional substance by all individuals accessing treatment in Ireland for all substances. So if you think about what the data that we have is telling us, so for FAST, alcohol is our second choice substance for men and women presenting. So that, and it's actually over a quarter of all services we provide. So from 28% last year. And then if you marry that with alcohol being the second substance of choice at 37%, if you do the maths, and I'm not a mathematician by any means, or an academic researcher, you could make the case that alcohol is dominating the service provision needs. So, like, obviously you could argue that, well, just because someone's saying alcohol is the second substance doesn't mean it's problematic. Now, my colleagues in the sector will know that if people are presenting with dependency on drugs and they have alcohol as a second issue, generally it's harmful or hazardous at the very least. So the HRB statistics that I have, and I know Sheila quoted 2020 figures there in terms of people accessing treatment, I've 2019. Over half of all those reporting report polydrug use. And of those half, 37.3%, that is alcohol. So that is actually the most reported. It's important to note that when we are looking at service provision and how we provide services in the future. And again, Sheila opened with this. I think there's an estimated 90,000 people in our country with a serious alcohol issue, but only 757 cases of alcohol use as a main substance reported in 2019. That reduced in 2020, I believe, but I would imagine, and I could be wrong, COVID has something to do with that presentation. I'm not sure. So if you look at this small portion of treatments that people are accessing compared to what the estimated problem is, there is definitely an under-resourced. It is definitely an under-resourced sector. So I won't go on anymore about the polydrug use end of it, but I think it's important. And again, this is just a snapshot of the national figures, which reflect our figures. Alcohol is the purple figure there, so it's consistently the highest second substance. I'm briefly going to go in. My screen is kind of taken over a bit, so I can't see it. So I just want to say that I've been asked to speak as the chief executive of an organisation in the community, and I'm by no means an expert in the area of providing healthcare services as per se. So I'm going to talk about these gaps based on our experiences. And I'm very glad to say that they've been echoed already. I'm echoing already what has been said this morning. So there's nothing that will jump out, but it's important to reinforce it. So the insufficient funding, I suppose, is a big one. And we all know that the sector is one of the most underfunded health services in Ireland. When I say the sector, I'm talking about problem drug and alcohol use and the family support elements of that as well. People really do fall through cracks. So it's that lack of integrated care pathways and no consistent model of care. While there is a great work happening in the sector and there's great services running across the country, it doesn't always, and it's great to hear Coolmine is probably unique in how it uses a therapeutic community model, but you can see that also the flexibility and accessibility and understanding of the many pathways into treatment and then many pathways of recovery. But a lot of services they adapt to a certain model, and it may not be consistent with a model in another organisation. And therefore, often referral pathways can be a challenge. Service delivery programs are based on that one size fits all model. And you often hear people talking about people trying to access residential treatment services. This is not a criticism, by the way. This is just a conversation, and this is something we need to explore. And it has definitely changed in the last few years, but this idea of having to be drug and alcohol free before you access residential treatment, I still am quite baffled by that. So, and I think there's probably elements of clinical governance around that. If there's not appropriate detox or medical support, that it is appropriate to not take risks like that with people's healthcare. So therefore, we need more support, that integrated support to have medical detoxes. But I think Jo-Hanna talked about there earlier on, when someone presents to a treatment service, if they don't meet the criteria for that service, it's like they don't fit the service, as opposed to us looking inward and saying, how do we make our services fit for people? And what is the presentation? And how do we be more flexible in creating pathways at that very initial access point? So insufficient and or no appropriate treatment response or care pathways for complex needs. Again, it's been covered. Dual diagnosis, trauma, and alcohol-related brain injury. Although Ireland is one of the top in the world consumers of alcohol, there's little that our society knows around alcohol-related brain injury, or indeed in the sector. And my own experience is very recent, because we have had referrals from care homes in Dublin around supporting people with alcohol-related brain injury. Medical health needs. So that hierarchy of needs, when people present with alcohol dependence, often have other medical health needs. And that could be a barrier for them accessing treatment if they don't have the appropriate support to support those needs. High-risk families, which have been touched on a lot this morning, women accessing treatment with already engagement with child and family agencies, and then homelessness. A need for more diversity and cultural awareness. So an inclusive service provision with fairer access for minority groups, and to include travellers, new communities, and LGBTQ+ communities. So it's actually, again, doing an inward look and saying, how inclusive are we of other groups and our models of care, and how much are we catering for one element of our society and say, well, this needs to fit. And again, talked a lot about women this morning and the diversity required for women, gender-specific programs to enable access. Because if people don't feel like who they are belongs in a support, or it doesn't fit, they won't go into it. So again, it's our responsibility to look at our services and provide accessible routes, and also communication. How we communicate. Google's great, as Anita has touched on this morning. But I mean, if you ever tried to Google a health issue that you have, by the end of that, episode of Googling, you can have yourself diagnosed with everything. Then I just have, what we can do. So these are just brief recommendations on what we can do based on research that has been done, based on my experience and our experience as an organisation. Obviously, developing and implementing an evidence-based model of care, which includes equality standard compliance. And what I mean by that is there is a lot of evidence-based models there working to support people with treatment, but I'm actually talking about more around that appropriate and accessible screening and assessment of alcohol use. I have ideas, or the SARE audit self-assessment tools online and e-health. Someone said e-health to me yesterday. It's the first I've heard of it, and I went online and had a look. That would be a really, accessible way for certain groups of people to access healthcare. And the online self-assessment tools are very good for people at an earlier intervention stage to assess their alcohol use issue. I have this highlighted because with all the work that we can do and all the great work that you can see happening in the services, and Anita has highlighted an awful lot of it, and Emma there, just in terms of the access and the catering for her needs that was available. The identification of need based on that initial assessment and the level of risk is core to create an effective system and a timely intervention and appropriate referral. An example would be somebody comes into an organisation or a service that is providing a model of care or a model they believe in. There are several models out there from traditional to contemporary. We make that person fit or not fit, okay, into that model based on the services that we provide, because that's our job. Sometimes people with identifying a more hazardous or harmful drinking pattern, but not necessarily dependent, get pushed back to the bottom of lists because we're always in that crisis mode. We are supporting and responding to people in greater need that have complex issues. So it's that firefighting piece of work that we're doing. So I think what's very important is how we identify and how we signpost and triage people for supports. That not everybody that needs support is alcohol dependent. Not every recovery pathway is about sobriety and abstinence. And we need to look at more and more of that earlier intervention piece. In earlier intervention, Andy will talk a little bit about that in terms of the continuum of care that he provides at that level. Appropriate referral pathways, again, establishment of central referral hubs across all healthcare areas for those identified at screening stage. So again, when people's needs are screened, that there is a referral hub in terms of meeting those complex needs around mental health, medical needs, etc. The good news is that I know in the healthcare area that we're in Dublin, our city and county, there has been a recent recruitment drive for an alcohol coordinator. My understanding is that the aim is to do this and to look at developing that integrated care model. Cross-sector integrated care team, most people with alcohol use, and Emma had touched on it there, have a co-occurring mental health issue or medical health issue. Complex needs, again, homelessness, high-risk family matters, criminal justice matters, and domestic violence. So again, having access to integrated care teams to address the holistic needs of people. Timely access to Tier 4, everyone's talked about it already. And in line with our Sláinte Care commitment, it's about having treatment for people when they need it, the right time, at the right place, and the right intervention. Because that's what saves people from, saves their lives, supports our healthcare system to be more efficient. And when people get put on waiting lists with something like alcohol, being alcohol detox or dependency, the time frame within that waiting on the bed can be quite detrimental to the person, to their families, and to their community. Significantly improve how we capture data that informs our current and future treatment needs. Okay, so I talked a little bit about the health research stuff there, and Jo-Hanna has done a lot of research in this field, and as Anita as well. In community organisations, small community organisations, there is no, across our addiction service sector, there is no standard reporting system. So depending on your resources, organisations adapt their own. So there's, I won't name them, but people know what they are. There's case management systems. And as well as that, we have our health research board statistics, the NDTRS monitoring. So we're reporting to two systems. And again, depending on the organisation, the resources will depend on how good your system is. So we're not getting actually accurate data from organisations on a ground level. And in terms of the HRB stuff, if there isn't a consistent case management system that we support speaking to that, we're not getting the information into it either. And I'm not a researcher by any means, but there is a frustration at a level in services that we aren't able to speak to properly the need for treatment in Ireland around all issues, especially around alcohol. So then the last 3 years, investment in upskilling, conducting training needs analysis and implementing a national training programme to upskill staff, an investment in current services and an increase in resources to meet growing demand. And finally, to echo what everyone has said already, an investment in recovery as part of the continuum, creating opportunities for people to build capital in order to have longer term sustainable recovery, education, careers, housing, health and wellbeing. I know I'm gone over, I can see my timer here, but thank you, Sheila, for not buzzing me. They're just a couple of websites that I've got the information from. So if you want to go looking yourselves, I'm sure we'll send the presentations around just in terms of that information that's available. And I'll hand you over to my colleague, Andy.
Okay, can you hear me there, everybody? Yeah, thank you. I just want to add a couple more points to what I'm conscious of the time, keeping people too long. Just a couple more points to add to Amy's presentation as well. When I think about alcohol, I think about, you know, everybody on that scale between the abstinent and the totally destructive. And one of the things when we're working in Finglas as people presenting is you see such a wide variety of alcohol issues, you know, from the kind of social moderate drinking, moving into more dependent, destructive drinking. So you get a whole picture then of the people who are brave enough to come forward seeking help. And you see so many different kind of presentations in that, people looking for help around alcohol. And one of the examples of that, certainly the last few years as well, is you would see an awful lot of people, even middle-aged people, a little bit younger, who are very used to some alcohol use on the weekend, but have kind of added cocaine into the mix of that as well. And along with that comes obviously the kind of destructive, more mental health stuff that can happen with that. So that's been a real shift in the last couple of years about people perhaps who wouldn't normally have sought help from any agency, but have got themselves into trouble because their drinking has increased through the add-on of another substance. You see other presentations as well. You see older people who perhaps had more social alcohol use, but as time goes on and things happen within their life, sometimes emotional difficulties can lead them to increasing that alcohol use as well, and that's when they can get into trouble. So they might come forward for a bit of help. You also kind of see perhaps older people who've been able to tolerate certain levels of alcohol, but as they get older, physically are not able to tolerate them levels of alcohol, and they may seek help for things that are happening for them. You may also get a lot of younger people presenting who don't drink often, but may binge drink, and with that binge drinking comes risky behavior and a lot of damage that comes from the relationships from binge drinking on very concentrated alcohol as well. So as well as other presentations, well, you see young people who are very young graduating quite quickly into more dependent kind of places with alcohol from quite a young age. And also another one you could add to that is perhaps people who are on methadone as they get older and become less tolerant of other drugs will shift into more alcohol use. So what I'm trying to say to you, I suppose, is that, you know, with someone like a CDT and people presenting for help, from our point of view, you see such that variety of people having difficulties with their relationship with alcohol. And when people come in, and what we're trying to do then is really just to kind of see for them, certainly one of the things to keep them coming and keep them talking about their drinking, trying to engage them in conversations that are around where they may fit in terms of getting help from seeking the support and encouragement of others, but also working with them with the information that's specific to them that will enable them to make choices and make decisions about the drink. You know, so, and obviously some of the things that happen with that is, and Amy's already talked about, you know, asking people to come into that group space. That group we have are based around the residence factor for people who binge on coke and alcohol at the weekends, and getting them into that group support, which, as we all know, is the real powerful thing sometimes in help is having encouragement of others from peers as well. So encouraging people into that, but also adding a little bit of one-to-one support around that. Perhaps bringing their partners in as well to have conversations about how best to support the person. So I think from the point of view as myself as a practitioner in the area for a long time, is always really about that sense of flexibility as well. It's really kind of meet people where they're at, and just to encourage them to keep coming and to keep talking about their drinking and to keep, you know, working with their goals around the alcohol use. And obviously if more significant help or more sustained help is needed for people with complex needs or residential help or whatever that may be, is to direct them appropriately to them kind of services when we can. And as Amy said herself, and we all kind of know, that can be difficult. There could be blocks to that as well. So, you know, that's really just what it's really just to talk about that flexibility as well, in terms of when you're working with people with alcohol. Obviously, in terms of then with people who are physically dependent on alcohol, in terms of community detox, you know, it can be difficult sometimes to get to the end of alcohol detoxification in the community. There's a certain level of support and that people need to reach that, because as we all know as well, sometimes people who are not able to get that full detoxification from alcohol will never get the clarity within their own mind to start to think about their relationship with alcohol as well. So that could be really important, that they're able to get into that space where they can learn about themselves and what's happening with the drinking and make kind of clear decisions. I would also, just a couple of other things as well to say that, you know, I'm always conscious that well, people, you know, alcohol is deeply embedded in the culture of Ireland, and that it gives people that sense of being able to talk and connect with others. You know, if we don't provide an alternative for that, people will continue to do that, to use that as a mechanism of connecting in relationships with others. And I think it's all well to talk about people seeking help and getting to more healthy places, but really we need to encourage our young people to find ways of connecting and being with others that doesn't involve alcohol, or find that space, because to stand outside of the alcohol culture, the drinking culture, is probably as challenging as it's ever been in this country. You know, yeah, and really that's it. That's all I really want to say as well. Thanks very much.
Thanks very much, Andy. I really appreciate that indeed. We're going to move on to our panel discussion. So I'm going to hand over to Paddy Creedon, who's chairing for this part of the event. And if people do have questions, please pop them into the chat box. We already had some come in there. Paddy, one thing just actually that really occurs to me, even just as we're talking here, is, you know, how can we better create the links that would make things easier? I'm thinking particularly here for GPs. Very often people, you know, in their first protocol, if they were to think about getting help, I think the GP might be the first place people, or one of the places people might go. But GPs, I think some of our participants have mentioned, don't always necessarily know what's available and what's out there. So just as a starter for 10 into the panel, you know, maybe that might be something to think about.
Sure, thanks Sheila, and thanks everybody. Could I just, and we'll pass that around, of course, that question. Just before that, just say on behalf of everybody here, first of all, to thank you, Sheila, for organising today's webinar. Thank you for that. To Jennifer, who I know is working on the technology there in the background and keeping the questions and all going. And could I just say to the people who came forward today, Jo-Hanna, who's, I think I was trying to find, just as people spoke there, what was the comment, you know, what was the theme running right through the whole day, you know, like for me. And I found that it started off really with this lovely phrase, I think, that you used, Jo-Hanna, about unfulfilled potential. And it tended to run right through the whole theme of today, you know, so I like that, you know, the human cost. And I know we often, and we use it, and I use it all the time, you know, the figures and the 90,000s, and there's just a name and a person behind every single stat, you know. So I think that was, and that theme was continued, you know. It was undelivered potential, unfulfilled potential, or to use that other phrase, unrequited potential, you know, what has society failed to do and not given back and not given the chance. Today we heard about all the, you know, the opportunities that are there for people to do that. So I want to thank you. Thanks, Jo. I won't get a chance, you see. I know we're going to wrap up real quickly, right? I probably forget to say thanks. So thanks, Jo-Hanna, for that wonderful presentation. And indeed, I read the report, and it's probably a huge amount of, not even, just a colossal amount of insight, and the recommendations in particular that you came up with in that report. I think we moved on then to Anita and indeed Emma, if I, you know, and again, that was the quality of life was used, you know, and the recovery capital, you know, and it's just such a huge role in the whole. I often think, you know, I know in America, for example, Faces and Voices quote things like that there are 24 million people in recovery and there's 25 million people needing recovery. And I'd love to see more of that in where we're going and how we can, you know, get that together. Like we're all on the one side in this, you know. So I think that just came across that whole quality of life and recovery capital. I think the one thing that you mentioned, Anita, that got me, and I suppose on the male side, we don't see that, you know, in a sense that the stigma and the fear of social services, it's almost a contradiction, isn't it? You know, social services are there to provide support. And then we have a real understandable body of people who fear them, you know, and I'm quite understandable. And I'll come to that back in a minute, but I'm just going to, I'll come to Emma maybe, if that's okay in the end, if you don't mind, Emma. But I just wanted, again, just mention to Amy, and I'm just looking at the notes, you know, I love that kind of idea of falling through the cracks, right? You know, that's what's happening with our services. Like there, you know, how many people are falling through the cracks? And maybe that goes back to your question, you know, Sheila, about, I've no doubt that everybody with an alcohol use disorder presents at some stage in their life in front of a GP. We had a wonderful pilot service many years ago where we had addiction counsellors attached to GP practices on a pilot basis. The results were all collated by I think it was the College of Physicians, or no, College of General Practitioners. And I think it went out as far as 8 different pilots around the country, where you went to your GP referred you to an addiction counsellor who was sitting in the GP practice one day a week or whatever. And it got over that stigma issue as well. So you were not seeing going off somewhere else. But I just like that idea of the falling through the cracks, you know, and again, that I think you mentioned, Amy, the whole inclusivity and the diversity and, you know, how important that is today, you know. And the question, I think, some kind of about fitting the services to meet the, you know, the need at the time. And again was the, you know, the thing that I got from that was the bravery of people coming forward, you know. And of course, it's the whole theme of today, this gap between the numbers that, I mean, there's massive numbers that need it and there's numbers that want it, and how can we close that gap? How can we actually, I often think, you know, if we did a campaign, a publicity campaign like COVID did, and the 90,000 arrived at the doorsteps of the services, at what point would we be just unable to cope, you know? And then there's the opposite of that says if we don't do something about it, the societal costs are just mounting up all every day. Emma, I have to say, God, and I think I reflect everybody, I'm even emotional at saying this, right? Number one, I'm a fellow traveler, right? So I'm in recovery, I'm in long-term recovery, right? So, and I think, you know, I just, even when you started off with your story, right, it was, you know, so reflective of my own, really, you know, of the family history and all that. And all so I just want to say, you know, my God, it's just, you know, you're in recovery since 2018, and it really goes back to the quality and the potential, right? You know, I was walking out of Bagot Street Hospital given a chronic alcoholic diagnosis by a consultant whom I never knew. And I wish I could shake his hand today. He was probably the most important person in my personal recovery journey, you know, and the potential it is. And you said it yourself, right? It's just, I just love that. That's the real essence of recovery, is that people, not alone is it unfulfilled. In your case, it's in 4 years. I think you said 2018, if I remember correctly. And now it's 2022, like it's long-term recovery. So anyway, that's my, I want to say thanks to everybody. And really on behalf of the people that have been on, and thanks for that. So the question was, can we do more to enlighten GPs, because we have GPs. So I'm going to throw that open to the panel, really. Anybody like to come in on that, or will I have to call somebody? Or Andy, I see you reaching over there for
I think that GPs see an awful. They have a tremendous amount of contact with people who have the beginning of alcohol issues, and it's very important that conversations with people about their alcohol happen before they get entrenched into more destructive behavior. So the more people we can get, professionally wise and GP wise, everywhere, to have conversations with people about their drinking, then the earlier you can begin to talk about that, then the more important that is, So because you said to yourself, Paddy, as well, there's only so much capacity any service can have, but there are a wide range of people, professionals, others, who can have conversations with people about their drinking, and very effective conversations.
I think you made that point very strongly in your own presentation, Andy, about at what stage of the continuum do we engage. We don't have to wait until that everything falls apart, that conversation could start a lot earlier. Thank you, Andy. Anybody else like to come in on that?
Yeah, just to say, I suppose the GP is an incredibly important especially when we're talking about community care. And just to out myself, I'm biased in the sense that I'm based in public health and primary care. So I happen to know a lot of really good GPs who are involved. But if we look at the kind of, I suppose, training of GPs, those who choose to go on to become prescribing GPs in addiction, we're singing to the choir with those, but really what we need to do, and I think we've been doing it in Trinity for the last decade, is getting and educating all doctors from from undergraduate level. And I think what we really need to do is make alcohol screening just something that GPs do routinely, so that it does become something that people can talk about, even when they haven't presented for that, but they might be dealing with that. So I think that that's a crucial thing. And I think equally GPs, and I know it's a growing kind of evidence, GPs also need to embrace the social prescribing, because the notion of getting other services in that can provide something instead of maybe providing a prescription or alongside a prescription, I think that's the kind of key to linking general practice to addiction services. So that's what I'd love to see happening, more of that.
Thanks very much, Jo-Hanna. Thank you. Yeah, sure.
So is it my turn? I never know until these things. One of the things that I think it happens informally is when people co-locate. So if you have if you have a GP that has a particular graph for supporting people and creating pathways around alcohol or drug use, would it be so out of character for us to work together by co-locating? So to have a community practitioner, a counsellor, or somebody in a community addiction service in a GP surgery, having that on-site care, providing care for people, timely. And, I often think if it's there in front of you at the time, you're more likely to engage, because, from our experience, and Andy will probably back this up, people ring for assessments and they're put on a waiting list. They may not come back. People are referred on to another organisation from you to them. They may not turn up. So I think the co-locating of services and teams actually in the same space is something that probably works. And I'm sure there's someone on this that will tell us that it happens somewhere as a good model.
Thanks, Amy. Thank you. Anybody else like to come in?
Amy, sorry, just to say that it actually is happening really well in Tala.
Okay, brilliant. Thanks.
Yeah. I think I'll just to, I suppose, just to add a bit to that, and I'm not going to think of her name. Jo-Hanna might say something. There was research carried out. She's a doctor, a GP in Cork. I think it's Dr. Mary Kelly, if I'm correct. But she'd looked at attitudes of GPs. She was looking at the issue of fetal alcohol syndrome, and she was looking at the attitudes of GPs. And I thought what was really interesting was it depended where the GP was located. So nearly a class issue had came in. So some GPs were really, really uncomfortable asking people whether they had a problem with alcohol, and she had found that depended on geography. And a bit like what Jo-Hanna was saying there, the ones was like converted. You speaking to the converted, those with addiction, as they found it quite comfortable, to ask. But again, these were located in very certain geographical areas. So I do think, you know, and as we say, I suppose a lot of people with alcohol, the first presentation they're going to make, nurses and GPs are probably going to be the first point of contact. Many people with alcohol issues are going to come into contact with due to falls or physical injuries or whatever, you know, and realistically, I think that is at the point where if we have a lot at that point, you know, really good at brief intervention or even just asking. But I think this is a first point. The conversation needs to happen about alcohol. And I think, Amy, and that we speak about it at an alcoholism level, you know, that's at the point. But there's so many different points in terms of binge drinking, youth drinking, young people drinking, and pregnancy. At any point, it becomes just a normalized conversation that people are starting to have.
Thanks very much, Anita. I know we're looking at the time. There was a couple of questions came in very early today, which I'd like to put to the panel as well, right? Our thoughts. One was to do with, they're both actually quite linked. One about how people feel about the necessary healing for family members who were impacted or loved ones who were impacted, and the healing around that. And the other one is linked to that, really, is the lead role played by family members in the whole recovery process of a loved one in addiction. And this is a kind of hypothetical, how well does the family member have to be really influential in getting somebody into recovery? So that's kind of a mixed match of some questions I picked up from, it's that whole role of the family, really. So maybe
I can answer that.
Yeah, sure, of course. Yeah.
Unless anyone else is. I think it's essential, and I think you know, we talk about family as a hidden harm, and more the impact of addiction on households and families is quite significant. And as you said there, Paddy, sometimes the family themselves need their own intervention outside of that of the person with the alcohol issue. That is often the case, you know, and people have literally turned up at our front reception with a family member saying, take them and help them. And you can see the trauma within the family. And I think one of the duties of care that we have is to support that and understand our priority, while at the time is the person with the alcohol issue, the family are also struggling. So you can actually, you know, you've got a space there where you can make an intervention that has longer term impact, because if families are involved, they are very influential, you know, and often they're the people that create that external motivation for people to change. Their family's going to walk out and they're going to leave them. So I think we are educators in that way to support families in their own rights, for their own support and how they manage their life, their children's, or, you know, their other parts of their family. But also there's models out there like community reinforcement and family therapy, the 5-step method, that will support people to understand their boundaries, to mind their own health and well-being, while motivating or trying to motivate the person into treatment. And I think families are another, family support is another very under-resourced area, Paddy, and I think it's very underestimated, and in the actual impact supporting families to support loved ones could actually have in the long run for people in recovery. Hope that answers.
Thanks, Amy. Thank you. Anybody else like to come in? I was really taken by Emma's contribution in that area, if you don't mind me saying so, Emma, and the role that and the, you know, that your partner played and where it is today. So I know in my own case it had a similar story. So I'm not sure if you want to just come in on that, or that's not asking you to do too much, maybe.
I think that my partner was, probably there was a time at the very start that he was definitely enabling me a lot. I suppose my drinking was all behind closed doors and he was the only one who knew, and I suppose my parents and siblings didn't know. And I think for his part, he just didn't know how to get me there. You know, we'd have had arguments behind closed doors, but he probably wouldn't have had an idea even where to start for looking for help. But now, as I said, he was out of the picture quite early on in my addiction. So I suppose when I'm thinking family, I'm thinking more my parents and how they'd supported me. I think, and as well, and I know it happens in so many addicts families, there's definitely a time when I would have been very much enabled by them as well in different ways. But I think quite earlier on, they were advised, probably like that craft that Amy mentioned, where they had to really enforce boundaries. I mean, like by them enabling me, it wasn't going to happen anything. And for a couple of years there, when things were really bad, my parents had accepted that I was probably going to die, because I made several attempts. I ended up in hospital a few times. They needed to protect themselves, and they also needed to protect my younger siblings. And my youngest sibling, my sister, was only maybe 13, 14 when I was going through all this. So it definitely wasn't the case that they could keep me in their house to keep me off the streets, because they knew I'd be drinking, and I would have been, that they had to, I suppose, enforce strong boundaries, but they were supportive too in whatever ways that they could be. And I think it's worth mentioning too, I mentioned St. Pat's Hospital being a big part of my journey, and I have to give massive credit to my parents for that, because obviously when I was homeless for a couple of years, I wasn't still paying my health insurance. They were helping with that. So that was the most practical way they helped. But I do think in the long run, you do have to be boundaried. You have to be boundaried and kind of accept that you're going to see your loved one putting themselves in really dangerous positions. Because if I wasn't going to get better for my son, I certainly wasn't going to get better for my partner or for my parents or anyone else, no matter how much I love them. I think you just have to take that out of it, because I think families tend to think, well, if I loved someone that much, then I wouldn't touch substance again. And it's just so much more difficult and more complicated than that. And at the end of the day, you don't get recovery until you at least get some little bit of shred of self-respect and love for yourself. And that's where Coolmine really worked for me, because you're treated with respect in there, but you have to earn the respect. You have to work your way up, and you have to, and boundaries is a big thing there as well in Coolmine. And that's just something I really learned, asserting my boundaries, looking out for myself kind of before anyone else, which sounds really selfish, but in the long run you get recovery, and then you are there for your family again. That was a very roundabout answer. I'm sorry.
No, it's great. Thanks very much. Thank you, Emma. Thank you. Anybody else like to come in on that one?
I'll just add into that. I suppose, I think family support is absolutely critical in a person's recovery journey, and our experience of it can be quite twofold, because I have sometimes concerns about where family support is going, also where that's turning to psychoeducational. So craft 5-step, absolute fantastic programs. But I also think they need to be combined with support. So they're in terms of managing your person's addiction or enabling, and very educational, absolute appropriate. I think in terms of linked with actually family support, where we're going to go back to this, the group and self-identification with other parents, because we all know, that addiction impacts every person in the family. And even with all that knowledge, and that knowledge to the families, the emotional connection to their loved one, and them feeling like a failure, and then also them carrying also stigma and shame. So we talk about stigma and shame of the person in addiction. What we experience a lot of time is family members that have become quite isolated, don't go out with their friends anymore, quite ashamed in their communities, because their child or whoever has robbed people in their community, so family members being very, very isolated. So I think we just never really need to underestimate the power of group and peer support in terms of family with family, supporting families, and that it doesn't become all just quite educational and psychoeducational. But as Emma says, it is, we find it's critical. Most people are returning to their family. That's where they're going, good, bad, or indifferent. They are their support structures. But I think another really interesting in terms of support, it's really interesting to see sometimes the families need to do some really good work on themselves, because sometimes they can be part of the problem. And, just from looking at some people's recovery journey, sometimes it might be decisions that their family is not in a position to give them the support that they require, or don't have the capacity. So even helping individuals kind of trying to distinguish what is supportive family and what is not supportive family, but in all the time supporting that family who may well have their own histories of mental health issues, addiction, that they're trying to manage. But I think it is, I think it's an absolute vital part of recovery treatment, if we're going to talk about retreatment and a holistic treatment plan, but the families are very much part of that treatment. But again, just little heeds of warning I can get sometimes when I see some kind of directions of maybe services, or that they may start leaning, like I always say, like the pendulum, goes from one extreme to the other. Family support, absolute fantastic. They brought in models of 5-step and craft, but that that's not the only thing, that there's actually a variety and a catalogue of family support that people can avail of.
Thanks very much, Anita. Thank you. Sheila, I know we're coming up on 1 o'clock, so.
I think we're just about coming towards the
Yeah. I know there's tons of questions and answers even on the chat line, so they'll all be recorded anyway. So with that, I just want to thank everybody again. Thanks to the people who, who were able to stay on and who attended anyway. So I'll hand you back to Sheila. Thank you.
Thanks very much, Paddy. I realised I was actually speaking and was muted myself there. I want to thank everybody on the panel, all our contributors. One of the things that we're very keen to do ourselves as Alcohol Action is to try and keep opening this conversation about the need for treatment. I just popped something into our chat box there about the need really for how do we pay for this. We can see we need more. We have some funding, but we need an awful lot more. And I think a levy on alcohol, the alcohol industry is one way of really looking at this because we're such an enormous problem. It has to be paid for. That, and the other key ask, I think, is a need for what I would describe as a national framework for trauma-informed services. We have a lot of talk this morning here about trauma and how we need to be able to address that fully, and we've a lot of expertise around the table here who I think could contribute an awful lot to that. So with that, as I draw to a close, the recording itself will be circulated. And thanks again to all our participants and to all our attendees. Good afternoon. So I'll just end the webinar there. Okay, thanks.